So this next talk is about how best we should use all the agents that we now have for patients with metastatic CRPC. Should we just sequence them, combine them, or perhaps individualize the way we're going to use them? So just to refresh your memory, this was the situation back, let's say, 6 years ago, when for patients with mCRPC, we had only the Taxane and zodonate to play with, and at least we've demonstrated activity. The Taxane overall survival, zodonate, as Noel already alluded to, morbidity was improved. No much than that. And it has changed dramatically thanks to all these agents, cabazitaxel, abiraterone, enzalutamide, radium, and I just put them in chronological order the way they came to us, at least taking into consideration phase 3 trial evidence. All these 4 compounds are associated with overall survival improvement. So the situation is getting much more complex now. For some years, we had abiraterone and cabazitaxel to be used for patients failing chemotherapy. Denosumab had replaced plus or minus zodonate. We already discussed yesterday the use of the Taxane together with castration for upfront metastatic disease. But things have changed in the last 2 or 3 years. And we're now using more and more abiraterone or enzalutamide before chemotherapy. And for patients failing the Taxane, we have now 4 options: radium, cabazitaxel, abiraterone, enza. So it's getting really, really complex, which is a good thing for the patients. So I'll be brief on that. I guess you know the data. Abiraterone in patients with chemotherapy-naive CRPC patients showing PFS improvement, overall survival improvement. I'll skip that one. And same data with enzalutamide in the PREVAIL trial. Again, PFS, overall survival were met. So how to use these drugs? Well, I guess there are several obvious situations where you can just say, I'm not going to use this drug. For example, a patient with a history of seizure, obviously enzalutamide is not a good choice because enzalutamide increases the risk of seizure. So please ask the question to your patient. A patient with visceral metastasis is not a good candidate for radium-223, at least as a single agent. Let's see what we can obtain with combination with abiraterone and enzalutamide or even chemotherapy. We have data from phase 2 about this, but single agent radium will just target the bone, as Noel explained to you, so not a good choice. Some patients are just too old or too sick to get chemotherapy, so you just can't. And some patients are obese with severe diabetes, just had a myocardial infarction, so they just can't get a steroid. And so because of that, they won't be able to get abiraterone. So these 4 situations are, I think, quite obvious, but please remember them, very important. Now, for the large majority of patients, what should we do? Sequential treatments, combo, personalizing. Let's review those. Sequential first. What do we have? First question, should we use or keep using the all hormonal manipulations? Bicalutamide, DES, ketoconazole, dexamethasone, etc., the one you like, before using the next generation AR-targeted drugs such as abiraterone or enzalutamide. 2 trials, Terrain, randomization of enzalutamide or bicalutamide in patients that I call as having early CRPC, so a patient who hasn't seen any drug that is associated with life prolongation. Just first progression while on castration. 375 men were randomized. PFS was a primary endpoint. And as you can see here, obviously enzalutamide does a much better job as compared to bicalutamide. It's less than 6 months as a median time to progression for bica, as opposed to almost 16 months for enzalutamide. Clear difference. Second trial, STRIVE, very similar to the one I just presented to you. The only difference is that some non-metastatic CRPC patients were also in the second trial. But otherwise, it's really the same trial. and by the way, the same data, as you can see here, marked difference. So what should we do with this data? I guess you can have maybe two interpretations, because we don't really have overall survival data in there. Either you say, well, the next generation drugs are better, so we just should forget about bicalutamide or these drugs and go straight to enzalutamide or abiraterone in a patient first progressing on castration. Fine, this is supported by this data. It's better for PFS. Or you might say, the next generation drugs are good, but very expensive. So perhaps I will give it a try for, let's say, a month with bicalutamide or quite non-toxic drug and cheap drug. I will see my patient again. If he's benefiting, fine, just continue and monitor. If he's not benefiting, then let's switch him to Enza or Abi. And I think these two options are very reasonable. Just choose the one you like. Now, of course, many patients are now exposed to abiraterone or enzalutamide, and after some time, they are progressing. And we need to find better solutions for these patients. So how to treat them? The first data, I guess, including all our own data, were a bit depressing because they really showed that there is a quite high level of cross-resistance between the two compounds. This is, for example, our own experience to the left for patients who have failed chemotherapy but also enzalutamide, and we gave it a try to abiraterone, but really it didn't really work with just 8% of patients benefiting, and the Canadian reported pretty much the same results, 3% patients achieving a PSA response. So this is probably not a good sequence. Abiraterone post-enzalutamide for most patients doesn't work. So you need to know that, especially if your patient is symptomatic, is probably not going to benefit. What about the other way around? Enzalutamide after abiraterone failure, perhaps a bit better, 20%, 25% response rate, but most responses do not last long. So again, not a very good scenario. And we don't really know whether these patients who are benefiting are patients who benefited long from abiraterone, as you might expect, but we don't have data at the moment. There'll be data out, hopefully, at EAU next year. So if ever you're using the sequence, you need to know that it's not going to work in most patients. All right? So this is very important, especially if your patient is symptomatic. Perhaps you should go straight to something else. Radium, chemo, experimental drugs, whatever, but probably not that one. If the patient is asymptomatic, well, you may give it a try if your country is rich. Now, what about taxanes? Well, this is probably a better news here, because the first data that came out from the Marsden supported some cross-resistance with abiraterone. It's not that true. And this is the largest experience that we have at the moment. It comes from the Q302 phase 3 experience. So 265 patients were treated after abiraterone failure with docetaxel. And as you will see, 47% of them achieved a PSA response, not far from what you would expect with docetaxel in de novo patients. And the time to progression was almost 8 months. Again, pretty much what you would see with docetaxel in an abiraterone naive patient. So the cross-resistant, if it's there between Abi and taxane, is probably mild. So taxane are probably still a good option for these patients. Same data, this is from our French experience, with cabazitaxel, post-abiraterone, and post-docetaxel. As you can see, most of these patients benefited from cabazitaxel. Obviously, there is a selection here because you will not consider chemotherapy for all comers. So please remember that not necessarily for all patients, but patients who were treated with chemo did benefit for the large majority of them. And this, we also have data from the UK going the same way. So taxanes, still a good option for Abi and very likely for Enza failures. So this is a proposed decision tree for patients with metastatic CRPC. I guess for most patients, especially if they're symptomatic and if the drug is available and reimbursed, I would support abiraterone or enzalutamide use because, again, they're active and quite non-toxic. If a patient is progressing, docetaxel would be my first choice, with maybe some hesitation with a switch to the other AR targeting drug. And we don't have much data with radium as far as I know in patients failing AB or ENZA. I wish we had some because it would be really interesting. Now, for patients failing all this, cabazitaxel and radium are probably reasonable options. Having said that, there are some probably exceptions. For example, a patient who is progressing quite rapidly while on castration, let's say after 6 months, 8 months, castration was started and is already symptomatic, then I think we should go straight to chemotherapy because in our experience, abiraterone or enzalutamide were not very active for these patients, while chemo probably is, even if this is nasty disease, obviously. And when the patient progresses, well, just do your best because we don't really know how to best advise these patients. Now, we're just about to see a new situation, and this new situation is that of a patient, the typical patients we discussed yesterday, upfront de novo metastatic disease. Now we're treating these patients more and more with castration plus docetaxel based on Chartered, Stampede, JTIC15, etc. So fine, the patients hopefully will benefit, but after some times, when it progresses, how to treat them? Until recently, we had zero data. The first data just came out at ASCO and ESMO. And of course, we covered already the discussion about denosumab. So what are these data? Because they're really brand new. In our experience in JTIC15, when you're using docetaxel as a re-challenge for patients who was treated with ADT plus docetaxel for hormone-sensitive disease, the bad news is that re-challenge with docetaxel doesn't seem to work very well. Just a few patients really benefit, as opposed to the control arm. This is a control arm who was treated with ADT up front, and when they received docetaxel for CRPC, they benefited normally, let's say, as you would expect it. So quite a big difference here with regards to docetaxel efficacy in CRPC. Now, the data that we have, and we'll soon have more data with abiraterone and enzalutamide, and again, this is still now limited data, suggests that these patients who are treated with upfront ADT plus docetaxel do benefit from abiraterone or enzalutamide when they progress as CRPC patients. Again, be cautious with this. This is retrospective analysis. The number of patients is still low. We should soon have more, but it truly suggested that these drugs work better than docetaxel. We'll need more data. What about combination? Well, this is going to be quite fast talk because so far so bad, with many combo failing to make any progress on top of a single agent. This is, for example, the many phase 3 trials that we had testing a new drug on top of docetaxel. I won't go into too much detail, but you can see all these phase 3 trials just failed to show improvement in overall survival. Now, perhaps we might have better combination in the near future. For example, targeting both the AR with enzalutamide, let's say, and the ligand with abiraterone might be better, but it's a might. We just have phase 1-2 data at the moment. This is the MD Anderson experience, showing that the combo is doable, non-toxic, no pharmacokinetics issues, and most patients seem to benefit by PSA. Now, whether this is truly better than ENZA or ABI alone, I just don't know. So we're just waiting for phase 3s. And there are indeed some phase 3s currently ongoing. Abiraterone and enzalutamide are being assessed in the US, and abiraterone plus ARN-509 is also a randomized trial as compared to abiraterone single agent. So we'll know in the, let's say, 2 or 3 coming years whether a combination of AR targeting is better than just one agent. Now, Noel already explained the rationale for combining radium with other drugs, and there are actually some phase 3 trials looking at this. The ERA trial is combining radium with abiraterone. It has completed cycle as far as I know, and the P3 trial is currently enrolling patients for testing ENZA plus or minus radium. So again, we'll know whether we should use this combination, yes or no. But at the moment, I think they're probably experimental. I can see that one. So what about personalized treatments? I already alluded to that during my previous talk about biomarkers, but really the V7 variants are emerging as a potential tool to guide us. Now, make no mistake here, this is for quite advanced disease. You have to probably, before using this biomarker, you have to have a patient who was already exposed to abiraterone or enzalutamide, and the question you're asking is whether perhaps you should switch to the other agent at progression or not. It's not necessarily for upfront CRPC patients because the V7 variants are very rare in this setting. And again, taxane work or tend to work regardless of V7 variant expression or presence. And again, I already showed you this data of a combination of AKT targeting plus abiraterone for PTEN loss cancers. So a phase 3 trial is just about to start to test this hypothesis. If it's true, we will make our decision based on a biomarker. So it's really personalized medicine. Other emerging biomarkers are coming to us. Again, DNA repair defects is probably a major thing. This is probably a very good solution for 15–20% of all the patients. And the question, I think we already had this question, perhaps to Noel Friday, is whether we should test all the patients with metastatic disease with regards to whether they have germline mutation. And I think this is a very important question for our societies, not only for the patient, because they might benefit themselves with these drugs, but also for their families. If ever you're able to predict for just one ovarian cancer in a lady, you might save a very important life and the cost will be covered. Just remember that. So it could be a very important question for all societies. Mismatch repair, that's quite rare in prostate cancers, but it's quite unique phenotype, and these patients may benefit from drugs, including immunotherapy. I don't have the time to go into much details, but the data are probably coming. So let's look into the crystal ball, and this is just a bet. What could be the future? Let's say in 3–4 years from now. I think that we will still be using abiraterone or enzalutamide, perhaps in combination. To be honest, I don't think we will use them together, but perhaps more together with radium-223, as Noel explained to you. But we'll see. Now, for patients with specific subgroup in the near future, perhaps for V7 positive cancer, we'll go straight to chemotherapy, or, and that would be very nice, remember what I explained with my arm. This is the N-term part. We need to invent drugs that can target that, because all drugs that we have are targeting the C-term part. These drugs targeting the N-term part are available in the lab. We need to know whether they work in humans, and the phase 1–2 trials are just arriving. So we'll see. For patients with DNA repair signatures, perhaps in the future we'll be using PARP inhibitors or just carboplatin, because carboplatin are pretty good drugs to do that and cheaper, but more toxic, to be honest. So we'll see in the future. And for PTEN loss, we need to know whether AKT targeting makes sense or not, based on the randomized data I just showed you. So in conclusion, sequential treatment is still routinely used in 2016. The cross-resistance between ABI and ENZA is quite high, just 20% responders. Taxanes are still active after ABI or ENZA, which is good news. Biomarkers are clearly emerging. If you think about it, 3 years ago, this talk should have been much simpler because we didn't have all these things. So it's a very rapidly growing situation. And combinations remains experimental for most of it. Thank you very much. And yes, thank you.